Good afternoon, everyone, and thank you for joining us for our May Geri Echo webinar. My name is Sarah Tomkison, and I'm a social worker with the Hub team. I'd like to give a shout out and thanks for our sponsorship. This CME activity is jointly provided by the Queens Medical Center and the University of Hawaii John A. Burns School of Medicine, Department of Geriatric Medicine. Joining me this afternoon is our interdisciplinary geriatric echo team, which includes Dr. Courtney Nunokawa, nurse practitioner. We have Susie Neufeld, who is joining us, and she's our physical therapist. Dr. Reese Ueno is our pharmacist. And last but not least, we have our geriatrician, Dr. Rita Bell Fernandez. Um, As a reminder, just a little bit of housekeeping. Evaluations for CME credits. You can now check on your CME credits online. This can be done by going to https://www.queens.org and then type in CME under the search tool. At that point, you can click on your My CME transcript to get a generated copy of the transcript. If you have questions, we've also noted here on the slide the email address for CMEs at Queens. Just as another reminder, in order to get those continuing education credits, you have to complete the evaluation form at each of for each of these webinars. So be sure you can find the link to the evaluations either in the chat at the end of this session or any other. You can also look at our website for that information as well. As the ECHO motto goes, all teach, all learn. And in the spirit of Aloha, we encourage you to all turn on your cameras to help us build this community of learning. Also, feel free to eat your lunch because good nutrition is key to our healthy lifestyle. The ECHO webinar format consists of a short lecture today from two of our expert presenters, and then we'll ask for comments from the expertise of the Geri Echo Hub team, followed by inviting you as the attendees to please ask questions, give case examples, provide comments. Lastly, we ask though that you please keep case discussions HIPAA compliant. So we've put here on the slide what we mean by the confidentiality and safety. Don't provide any names of the patients, of the case examples or their birthdays, etc. So at this time, I'd like to introduce our two guest speakers. First, we have Miss Carol Hayashida. She joins us with Unite Us. Back in January 2021, Carol was instrumental in launching the Unite Hawaii Network. In her previous position as Senior Community Engagement Manager, she had also spearheaded United Hawaii community engagement efforts. And before coming to Unite Us, she was also the Community Engagement Manager for the Hui Ho'omalu program at Partners in Development Foundation. And in this role, she supported the statewide recruitment of resource caregivers for children in foster care. She is driven by a deep passion for fostering community collaboration to serve local needs. Carol brings a wealth of experience and dedication to her work. Our second guest speaker on the topic of social determinants of health is Ms. Valerie Gourley. Valerie is an experienced population health nurse manager with a strong background in nursing, healthcare management, and service coordination. She holds a BSN from Hawaii Pacific University and has an MBA degree in healthcare management. With over 20 years in healthcare, Valerie has led initiatives to improve clinical outcomes and manage long-term services. She is also an active member of several professional organizations which includes the American Holistic Nurse Association, the American Organization of and the Organization of Nurse Executives. Please join me in welcoming both Carol and Valerie. Thank you, ladies.
Thank you. Nice to meet you all. Thank you all for inviting me to present today. I'm going to go ahead and share my screen. And everybody can see that okay? Great. Okay. Quick little bit about myself. I am as I said, with nonprofit prior to coming here. So really the heart that I come from is just the heart to see community connect. And that's really what brought me to this work is actually what brought me to this work is seeing the disconnects in my nonprofit work is just seeing how there were so many silos and we didn't know what other organizations were doing that were right down the street. We couldn't connect our clients to care. A lot of failures personally I felt that could have been prevented had we had a little more insight and a little more connection within community. So that led me to this work. I was just super frustrated and knew that there had to be a better way. And so that's how I came to Unite Us. A little bit about social determinants of health. And as most of you know, they really are the non-medical factors that influence health outcomes. So things that you think about that affect a person's well-being, housing, education, access to food, um, any type of air, water, language, literacy, education, all those things affect a person's overall health. So really what Unitas is trying to do is support the addressing of the SDOH so that people can take care of their clients, not only holistically, not only medical, but also with their social needs. So just a little bit about a background of why Unitas was founded, really by two veterans who back in 2013 were discharged from the service. One was medically discharged, and he found it very difficult to navigate the system. And couldn't figure out how to even get, the neat services that he needed. And that's from the lens that they came. They founded this organization because they wanted to see a better connection between healthcare, social care, government. What if we all had insight into what each other was doing as far as supporting a client's social needs? So I'm going to go ahead and talk about some of the organizations and what that looks like. And I'll share a little bit more about it, but I just wanted to share some of the organizations that we partner with. We partner with over 240 organizations statewide. Our network is statewide. And so you can make a referral across states, across state lines even, but especially across county lines, which is really nice. And I'm just going to give you a couple examples of organizations that we partner with. There's so many amazing organizations out there, and I've had the privilege of connecting with so many and learning about not only the work that they do, but the dedication to the work that they do. Late hours, just a lot, so much that they do to support their clients. One is Salvation Army Community Assistance Center. For Caputo, they have two programs. One's for 62 and over, and they have specific eligibility needs, but anyone facing disconnection from utilities. And the other one is a Capuna program that helps with any type of needs that a client might have if they meet eligibility. For instance, utility bills or house cleanup. I think we had somebody come and do some house cleaning, and they provided that service to the vendor directly. Another one for housing and shelter. This is for Honolulu that just joined our network's YWCA Fernhurst program. And they're a transitional housing program for women. You have to be a resident of the wild for the last 3 months and facing homelessness. So those are an example of two programs. I just picked a couple really good examples of people that I'm working with that provide these different services for the community, and referrals can be made directly to them on our platform. They're partners with us, and then they can pick up their referral, accept it, put the outcomes in, and then close it so that everybody knows the sender. Just say the sender was Aloha Care and they make that referral. They would know what happened with the client, how was he served, what was the outcome. And so they can track that piece and really know when they're working with a client what's been happening with their care. And another couple examples, anyone who was on Hawaii Island, we have a couple programs that are really fantastic over there that I wanted to highlight. HCEOC has a transportation Ka'ohokele program. It's a shared ride service. As you know, Hawaii Island is so big and has some transportation issues. So this program really stood up to help support the community in that way. They're a really great program as well. And then Hope Services, I think most people know about Hope Services. They are a huge organization on Hawaii Island that does everything from homeless outreach to homeless prevention and diversion to emergency housing. They have a gamut of services. They're wonderful partners with us as well. So our team, anybody on the network can send referrals to them as well, and they can respond to those referrals. Statewide, couple programs I wanted to highlight. One is a utilities program. This is really been a lifesaver so for so many members because if you don't have a connection to a phone, you don't have a connection to get Social Security benefits, to call, to get MedQuest. There's so many things that you need that actual phone for. So Lifeline is that really starter program to get somebody going so they can actually connect to other services. It's a federal assistance program. They're a partner with us on the network. Just fantastic to work with. We have so many referrals going to them. It's really hard to keep up, but they're just doing the best they can to get to serve the members out there. And then finally, housing and shelter. This is a great program that I think a lot of people aren't aware of by CNHA. It's for their Kapuna Rental Assistance Program. And if a client is on the waiting list for the DHHL, it is very specific, but and they meet this Kapuna residency eligibility, they can qualify for rental assistance. And that's a really great program that I don't think people really knew about. And they were excited to join our network as well. I wanted to just give you a little insight into what does it look like on our network? What does that look like when a referral is made on Unite Hawaii, and what does the outcomes? How do we know what's happening? And because that's been the biggest thing. I don't know if I send a client to a service, I don't know if they ever got there. I don't know if they made it. I don't know. Most of the time they don't. And this really is helping to solve that problem. So this is a true success story that happened. A member was struggling to pay rent. She had a fixed income of $2,000, and not much left after paying $1,300 rent. So where is some of the losses? She's probably not getting, maybe she's compromising her food by not eating healthy food. Maybe she's compromising her medicine by not picking it all up because she only has a little bit to work with. A referral was sent to Mokihana at CNHA. She responded to the member and she said, with the help of the family support, they helped her get all the paperwork together. They submitted that paper within 24 hours. The request was approved, and this member is currently getting a stipend about $600+ to a monthly to support their rental assistance. And in her letter back to Mokihana, she said, "I firmly believe CNHA was chosen to come to my aid." And that's a really great, just a great success story because we're seeing that we know not only was a referral sent, it was responded to, somebody got help, and it's really affecting their social determinants of health and their overall health as well. Okay, this is just a little snapshot. I wanted to give you a snapshot of our partners. I said we have 240 partners. I think the question that comes up is, does it cost anything? And so for our nonprofits, anyone who provides direct service, our FQHCs, they all come on at no cost. So we've been able to just bring on a lot of organizations. What we want to see is cross referrals going across not only from our healthcare partners to organizations to organizations. So everybody has insight within reason, not certain sensitive types are hidden, within reason of the basic information of what that client is facing. And just so you know, we are HIPAA compliant as well. So we full align with all the federal privacy guidelines, 42 CFR Part FERPA and FERPA. So we have a lot of those things because we work across the country with healthcare and government. And then this is our neighbor island. So I'm not sure if any of you are on the neighbor islands, but if you are, we have a pretty strong network on Hawaii Island, working on Maui and Kauai. So I've been at this work for 4 years, and it's a process that keeps moving forward. It's not like this is it. It's how do we continue to bring on new partners, increase collaboration and partnership, and how do we help people to have insight to really support a client's SDOH needs so that we're improving their overall health. So I think that's all I had for today. I want to thank you for the time. I'm going to stop share and I will pass it to Valerie.
Hello, everyone. Thank you. Let me share my screen. Okay, so I am going to talk about our GRACE program implementation. And part of our agenda is a GRACE team model development by the University of Indiana, as well as our Aloha Care GRACE model and a member response. A little bit about myself. I've been with Aloha Care for 10 years, and I have over 20 years of healthcare experience in different capacities. I've been bedside nursing to case management. So I do have a wealth of information. So the GRACE team model, which was developed by the University of Indiana, GRACE stands for the Geriatric Resource for the Assessment and Care of Elders, team care. And the team model is to improve the health care of older adults. Our GRACE model, as I mentioned, is developed from University of Indiana to improve the quality of our geriatric or kapuna care, to optimize our health and functional status, and help to decrease hospitalizations, emergency room visits, prevent long-term care in nursing home placement. And it help, I like to say we are the liaison between the healthcare system and the members, just because it's difficult sometimes for members to manage it. The model focuses on addressing multiple geriatric protocols, such as advanced care planning, health maintenance, making sure members are compliant with their follow-up appointments, medication management, ensuring that members are able to get their medicines and they're not sacrificing eating to eat versus picking up their medicine, with difficulty walking and falls, depression, dementia, especially caregiver burnouts, or with especially multi-generational families living together, chronic pain in our population, as well as malnutrition and weight loss, urinary incontinence, visual impairment, and hearing impairment. Aloha Care's GRACE model, team model, is the member being the center of our whole, what we do. We see members by a GRACE RN, myself, or an LSW, which are the primary leads. We visit the members in person. We develop care plans with the member, whoever they choose to participate in there, as well as our GRACE team. And we do internal IDTs every week with members, and that includes our pharmacist, our geriatrician, behavioral health, any others that need to be a part. We do ongoing assessments and monthly contacts. So we do call the member every month. We do see the member face-to-face every month. And if those need translations, we also provide translation in person as much as possible, because they have voiced it's very hard to complete assessments telephonically with the translator. Just sometimes things get lost. So a little case study. This is a member that was referred from one of our providers. She is a 59-year-old Filipino female. She was referred to our GRACE program by a PCP. She had lots of chronic conditions, congestive heart failure with a EF ejection fraction of 10 to 15%, chronic kidney disease, stage 3A, PTSD, housing instability. I did not personally do this assessment, but I've had a lot of interaction with her prior, and was a part of helping to navigate some of her issues. This member was houseless, so the assessment was completed on the streets. She was disheveled. She was difficult to engage in the assessment, and hard staying awake. She was walking with a walker, and her PHQ-9 was 13, significantly high. Prior to GRACE intervention, she had multiple ER hospitalizations, going to the ER at least, I'd say, 4 or 5 times a day. We assessed her problems with, as I mentioned, depression, houselessness, noncompliance with medications and medical appointments, as well as new onset of drug abuse. With the GRACE interventions, we were able we were able to connect her to our community integration services, a CIS housing referral. So she got somebody to help assist in finding housing for her. As Carol mentioned earlier, the Lay Foundation, we were able to get her connected. She had no way of communicating with providers such as the CIS housing caseworker or anybody in Grace. So we were able to get her a Lay phone. She still has that Lay phone and she is currently actively using it. Prior to some things that have happened, we picked up her medications and hand delivered them to her multiple times. We worked with a PCP in helping to lay out medicines to know when she took it and what time she should take them. Unfortunately, because of a lot of her chronic issues, she was admitted for an extended period of time. Post-discharge, I was able to complete an assessment with her face-to-face. A total night and day transformation. She was very engaging in the assessments. Her PHQ-2 was 0. She was alert and oriented times 3. She was walking without a walker or shortness of breath, and she was very well groomed. We got her reconnected with CIS, her psychiatrist, and her PCP. She is currently residing in temporary housing for medical respite, as well as we've collaborated with behavioral and respite housing to help her get multiple other social determinants of health issues completed, such as applying for SSDI and transportation to and from medical appointments. So her outcomes have been improved mood, improved PHQ-9 scores, she actually significantly improved her relationship with her family. And since her discharge, she only had 1 visit, which unfortunately was unavoidable. But from going 4 or 5 times a day to once since February, I think that's a great achievement for her. Her blood pressures are within normal range, and she is totally compliant with her medications, as well as following up with her medical providers as she continues to live in the medical respite housing while awaiting housing through CIS. Is there any questions or comments?
Sarah, you're on mute.
Okay. Sorry. So, yeah, I'm sure there's people in the audience. So if you have questions, please enter them in the chat. And as you're doing that, I'm going to ask the Hub team for their comments and any other insights they have about what was presented today. And maybe we can start. I don't want to speak first, Courtney. I'm always asked to speak. I can always speak last, but I'll start with Courtney and then go to Reese and Rita Bell and lastly Susie. Okay, Courtney.
Thank you. Thank you both for your great presentations. I think I think we all probably experience social determinants in practice. And so both of these presentations were really helpful to give us kind of real time resources to help mitigate some of the negative outcomes that are associated with it. So I'm really appreciative of it. And GRACE is something that we teach in academics as a model of care, a standard model of care. So it's really great to hear about how it's being implemented. And kind of in a selfish way, if you ever want DNP students to get involved, I think we would have several DNP students would be really interested, both from a direct clinical care standpoint and also just any evidence-based practice, QI type work. Because I know it always kind of feels like we're climbing against a mountain with some of the social determinants things. So thank you.
Good. Reese, from a pharmacist standpoint.
Yeah, no, thank you. Wow, thanks, Val, for that summary of the GRACE program. Really seems to do everything. But just wanted to follow up. You might have mentioned this during the program, but how does a patient get into the GRACE program? Can they be referred directly from like the pharmacy, for example, or does it have to be from the PCP? And would it be for patients with Medicare and Medicaid, or just Medicare patients?
Great question, Reese. So the criteria, currently we have three providers that we are participating with, because a part of it is intense collaboration between the providers and the GRACE team. So access to their EMR, KKV is one of them. The referral can come through a PCP. I also pull reports. It can come through a pharmacist if you feel they could benefit from the GRACE program. They have to have Aloha Care as primary insurance. So if they have Aloha Care for their Advantage and have another insurance, that's no problem. We can put them in GRACE. If they have GRACE or Aloha Care as their Medicaid primary only, no problem. We can take them. They have to be, our criteria is, and we found this, and I think Dr. Wen can, who introduced the GRACE program to Aloha Care, can chime in too, is we noticed that a lot of the younger population has a lot of geriatric conditions. So we actually, our age starts at 50 on up, and I think we have, I think our youngest is 50 and our oldest is about like 93. So we have a huge aspect of it. Have to have 2 or more chronic conditions. They cannot be getting active dialysis, and we hope that they're not actively using methamphetamine or higher substance drugs. Unfortunately, that sometimes happens after they've come onto GRACE. So we try our best to work with them as we did PM to kind of resolve those issues, or help them get connected to resources if they express wanting to quit. Multiple ER or hospitalizations within the last year. This one was obviously lots of multiple ERs within the last month. So those are some things that we look at, as well as their primary diagnosis can't be an SPMI. Depression, anxiety, things like that. I have members that are in our program like that. Currently, we have, I think, 78, 79 active members in GRACE at this time.
Thank you. Your thoughts, Dr. Fernandez, on either program, Unite Us or?
I wanted to share a little bit about CIS, because this case that was presented by Valerie was enrolled in CIS, and I don't know whether everyone on at this ECHO knows what is CIS. It is Community Integration Services, and this was championed by Maddie Silverman. And may she rest in peace. Maddie took this project on and really got CIS started at MedQuest. So all the health plans, HMSA, Ohana, United, everybody offers CIS services and pays for CIS services. So what is this? This is targeting the homeless population. So housing is an important social determinant of health. And to be eligible for CIS services, the MedQuest member needs to be either homeless or at risk for homelessness, and they need to have a health criteria like behavioral health need, a serious mental illness, or a complex physical health need. And what the CIS provider does, it helps them with pre-tenancy navigation. I mean, that's just a jigsaw puzzle to find out what housing you can qualify, how to apply for the housing. It also helps them with tenancy stabilization services. So I just want people on this call to know that CIS program is out there for their MedQuest members from all plans. And Kali Palama, where I work, is one of the providers for CIS services.
Thank you for sharing that with everyone, the definition and purpose of CIS. Your thoughts, Susie, from a physical therapist? Oh, you're muted.
Uh, do you work with the Harry and Jeanette Weinberg Senior Apartments?
I have been to lots of public housing or low income housing. I can't remember all their names. I'm
Okay.
sorry. But I have seen their names out and about. So I'm gonna say yes,
Okay.
just because I've been through so many.
Oh, okay. Okay. And are you finding that money, federal money is still available for these programs?
As of right now, yes, I am. I haven't so far any of my members that are active in Grace have not lost any of their benefits from a community, from an SDOH point of view. They're still actively getting, their phone service. If assistance with any other referrals that I have put in for through Unitas or any others. I have not seen anybody so far, knock on wood, lose any of those.
Right.
Or tell me that they've gotten a letter stating that it ends at a certain time.
Okay,
And
that's
trust
good.
me, they save all their letters for me to look at when I come.
Oh, thank you.
Thank you.
Hi. Thanks so much, guys, for talking about the importance of SDOH. In many ways, the healthcare system has been hyper-focused on acute care and high-tech care, and just kind of for years, right, decades, right, ignoring that SDOH. But in reality, we all know, right? It's the older adults are the most vulnerable to poor outcomes, and it's because of those SDOH factors. And so really it's providing that new model of care where if you bundle everything together and you put more efforts and make the social determinants of health, you can address those more satisfactorily. That's when the patients and the families succeed, and that's when the healthcare gets less expensive. It's really I'm just a huge fan of that, and I'm just really proud of the work you guys are doing.
I'm just going to add to what Dr. Wen was saying. Maslow's hierarchy always refers to the very basic needs. And I think both your programs are addressing the foundation at the bottom. You have to be able to first, find housing, secure, stable housing. And it's really hard if people are worried about where they're going to sleep that night or what are they going to have to eat for the next morning. So housing and food and money are so critical. You can't really begin to look at, the other factors that he talks about towards self-actualization. You can't provide counseling or get people to think about rehab, whether it's a drug rehab program or anything else. So I think you've both highlighted that. I had just a couple of questions for each of you. The first, Carol, I love how there's more than the 200 organizations that you've been able to unite them and kind of see how they can work together to do these cross referrals. Have you found in your current experience, is there any thought about the use of faith-based communities? Because oftentimes I think we overlook that there's synagogues, there's a lot of churches and parishes. Everyone's doing their own thing, but it'd be nice to have them connected somehow too.
That's a great question, Sarah. And actually, our founders said that they believe the church is the heart of every community, which we know, right? They're serving the community. So absolutely, we really want our faith organizations and to be part of this network. We encourage them to join because we know that not only do they know the needs of the community, but they also take care of a lot of needs of the community. My church has a Kapuna exercise ministry, and I would love for people to know about that. And there's so many churches out there, and part of this movement that we're also doing is what we have, that faith collaborative, is bringing the faith community together to serve. And how do we do it? Because everyone's small, but if they come together, they become a bigger force to support all the needs out there, those SDOH needs that they do so well. And they do it not because they want to, because they love their community and their people. And so that is definitely a big component that we think is very, very important and a part of Unite Hawaii that we'd like to continue to foster.
It's wonderful. And then the other question I had for Val is you mentioned that one of the services that is available is addressing caregiver burden. So in with I guess your organization, what kinds of services or programs are you trying to implement to reduce caregiver stress or burden?
Well, there's a couple. Especially if the members have dementia, and family members are taking care of those that have dementia. I know I give them information on the Alzheimer's Association and their support group, as well as different community hospitals provide support groups for members with or families that are suffering with dementia. If it's grieving process because they've lost family members, if they don't feel comfortable talking to their provider about getting connected to a behavioral health specialist, a counselor, whatever, I look at, what church do they go to? As your example is a faith-based, because some churches do have a support system for whatever, whether it's grieving or whether it's, having to take care of their family members. And just that burden, having somebody to kind of understand and relate to them is super important to them. Some have used it, some say, no, I have a good support system. But every assessment and every interaction I have with the members, I'm always asking, like, how are you doing with the caregiver burnout? Are you still managing okay? Don't forget we have these resources. So it's a touch point as well as doing medication compliance at every interaction with the members.
Do you use any kind of tools to assess burden, like the Zaret, the Zaret score, caregiver burden scale? Does it?
I have not used that.
Okay.
I just questions are like, how's your day going? Do you feel like frustrated? Do you feel like lashing out? Things like that. And then I also look at how their members are interacting with their caregiver or their family member, because actually that tells a lot. You can lie to my questions, but watching that interaction, you can't really lie about that.
So true. Yeah. How about our audience? Do we have any questions, comments from our participants?
Hi, I'm Derek Bound, public health nurse. Thank you for the presentation. I just wondering where I can find out more information about Grace and, sorry, it's escaping me. Is there a website?
It's in the PowerPoint presentation for both of you. I saw
Yes,
Valerie's content.
Yeah, there's my contact information in the PowerPoint presentation. If you have any questions, please don't hesitate to reach out.
And then Carol, did you have something you can put on the chat with a contact or website?
Yeah, I'll throw my
Nice.
contact information as well as the website that you can connect with. But yeah, I'll have my contact information. Feel free to reach out.
Thank you.
John, would you like to tell all our attendees where they can find recordings and handouts of the ECHO, please?
We do have a website, and I will put it in the chat for everyone.
Dr. Wen, did you have any other additional comments about the GRACE program, which you were instrumental in bringing here to Hawaii through Aloha Care?
Yeah, no, it's a fantastic model. It was started at Indiana University and they piloted it, and they demonstrated success in multiple health systems like the VA and community health centers and academic centers and all kinds of things. And when we brought it to Hawaii, and I shared it with folks, Aloha Care snapped it up right away and they made a new innovation, and that innovation was to include a health plan into it, which I think is genius, because instead of always having to get prior approval from the health plan, you got it like instantly. Yeah, because they're the ones that are recommending all of these extra supports. And it's not just social determinants of health. Actually, there's a geriatrician and behavioral health specialists on the interdisciplinary team that meets every week. And they, basically do that consultation and feedback for information to the primary doctor. So it's a very efficient way of getting everybody's input, that team care approach with geriatrician and pharmacy and behavioral health all integrated together. So I'm just really proud of folks, and I'm hoping, I would just wish it would be scaled up and like everybody would do it.
Yeah. Yeah, I wondered, Val, you said you had right now, I think it's 79 active members, and I think what really struck me is that you do home visits. And that's, like you said, the best way to see how to see how your clients are really doing is if you see them in their own environment. It's I would think it's pretty time consuming and labor intensive to coordinate all this. So what's the ratio for the number of clients to social worker? Is it a social worker / nurse team, or is it one or the other?
Originally, it was a nurse practitioner and social work dyad, and that dyad could handle 100 clients. We've actually adapted it further, right? And so now, we actually are able to make successful, not with a nurse practitioner, but with a nurse, and then social work. I think there's thoughts of extending it to like CHWs as well. So I think there are even greater efficiencies that can be found and yet still be effective.
Yeah, be curious to know how much money they really save, because Val, you've cut down on the number of emergency department visits, admissions to the hospital. For those that do discharge planning, keep seeing the same patients that keep coming in and out. Do you have data that you can share with us about how much
we do have some data. They have to be active in the program for 18 months to really actually see an impact. So our data from 2019 to current is kind of limited. But what data we do have does show that we have decreased we have saved the organization money, as well as decreasing hospitalizations and ER visits.
So I don't know if we're going to get other health insurance companies to jump on the bandwagon, Dr. Wen. Hello, it's a no-brainer.
Yeah, it's a time commitment for sure. And there's actually, because we do have access to 3 EMRs, we have much better response and communication and collaboration with the providers, because we have that quick response versus having to call the office and wait for an appointment, or say I see a member today, and if there's like key things that I feel like they need to kind of be addressed right away, I can easily send the providers a message helping them get connected to or reestablish some of the members I've seen recently have not seen their PCP in over a year. So it's like, okay, how come? What can we do to help you get reconnected? Is it like you need help scheduling? Do you need transportation? Do you need an interpreter? Sometimes it's all three, sometimes it's two out of the three. So I also help facilitate translators being at medical appointments or treatments and things like that. Whoever's involved just sends me an email and I put the request in.
You know, following up on Courtney's her statement, any chance that you Grace, I don't know, maybe you do have a training program, but I'm not sure how expansive, because it takes it's finding preceptors, it's finding space, but you have such a wealth of experiences, and I mean, it's how can you make sure that our up and coming nurses, social workers, doctors have this opportunity to learn firsthand
Actually,
about patient centered.
we have been using it as a clinical site. Aloha Care has been very gracious in allowing that. And we just do it. It's a very small number of participants each year, one or two nurses each semester, one or two social workers. Actually, in Aloha Care has student pharmacists embedded in there as well. And every so often we have maybe a geriatric fellow joining the team, but it's little bits.
Yeah.
Yeah.
Before I took over the program, I know Dr. Nguyen had participants that shadowed along and participated in observing the assessments and giving feedback and things like that. Since I've taken over, it's been a challenge. We've gone through some transition, but I'm open whenever she's ready to send.
So I have a question for Carol. Is your program, is it mostly just a website and you just navigate it, or are there actually people to talk to and consult with?
That's a great question. It's a network, so it's a web-based platform. And so all our organizations, we onboard them. We have a whole operations team that brings them on. They sign these service level agreements that they will respond to referrals within a certain amount of time. So it really is we call it an accountable network, meaning that if you just have a network and you have people on there and nobody takes a look at it and makes sure that people are using it, then it just sits there. So the whole idea is that if a referral is made, we ask our partners on the other end to respond within 3 business days, to make 3 tries to the client over 10 business days, and if not, to close it. If they do respond, we also ask them to accept the referral, take action on it, reach out to the client, and then close it as resolved or unresolved. So that the sender, so in this case, Aloha Care, if they sent that referral, they're going to know, did that client make it to that organization? And if so, what happened? And even importantly, for community perspective, if they did not, if the referral was rejected, say for housing, because we all know this big shortage, the why, at capacity, which we see a lot, at capacity. And then you start to get a bigger feel for why are referrals being rejected, what's going on in our community. And then we talk about community impact. Then you take some of that data, which is what we really believe in, is the data that we provide back to all our organizations and healthcare plans, to say, this is what's going on. These are the needs that you have. These are the needs that are being addressed. That are not being addressed. These are even the demographic referrals. What does health equity look like? How are we serving one population over another? So that's all integrated within the network. We have it's organization to organization referral in general. So the organization does respond, because what we want to do is we don't want the client to navigate themselves, right? It's often hard and they don't get there. So the whole point is, if an organization is making the referral to another organization, that organization is going to wrap services around the client, and it's much more effective. And you see a lot more of better outcomes because of that, because that client, I've seen in my own work, the client never gets there half the time. They don't even pick up the phone to make that call. Even in a warm handoff I've done many times, didn't work. But what if the organization wraps services around the client? What happens there? So we do follow up. So if a referral sits too long, our network hub support team reaches out and makes sure that somebody picks it up. So we say, please pick it up, please make sure you respond, please close, things like that. And we have a support team that's online to chat with from 9 to 5 Hawaii Standard Time. So it's all the ways that we want to support because it's not just the network, it is the people behind it and the relationships behind it. So that's how we do what we do. We believe it has to be accountable in order to be healthy and in order for it to make an impact in the community.
Thank
So,
you, Carol.
so Carol, is Unitas like a clearinghouse of these community agencies that people can access? And are you you're the staff member, right? I mean, I know there's people online to oversee if the referral gets answered, but it sounds like it's your you're the one person doing it all.
I couldn't do it all. Absolutely no way. But
You also,
I'm the Hawaii person. Let's just say I'm the face
oh,
of Hawaii.
why?
So I work because I started in community engagement when I first started 4 years ago. That was my background. I work with all these nonprofits and to bring them onto the network. So that's how I connected with all of them and just the privilege of knowing so many of them. They're so great. And then I work with healthcare partners who are partners with us on the network as well. So I'm more of the face, but behind me is a team of operations and analysts and people way smarter than me doing this technical work that's behind it. So even though I'm like Hawaii, they allow me, what I love is they allow me to be very community focused. I told them right from the beginning, Hawaii is grassroots. We're not like New York. We're not like California. We are Hawaii. And you need to understand how we navigate relationships. And they've been so great to say, go, do what you need to do, build that network. And it's also built on just not technical, but partnerships. So we do a lot of live in-person partnerships. In fact, we're doing with Aloha Care next week, where we bring partners together because you have to build trust. And so if you just see a digital referral and a name, you often won't make the referral. But if you see a face and you put those two together, that's when you see success. And so I believe it's really important to have both components, the community, the relationships, but the digital platform that provides that data for everyone to have access to. And also, when you look at a client, you can see all the referrals that they've had over time. So one client might have 50 referrals over a period of 5 or 10 years, and everybody gets insight into what kind of referrals they had and what kind of needs they had as well. So we have in-network and also out-of-network directory. So we have a resource directory for our partners, and we also have a resource directory for our off-platform partners. So it's the full gamut of both sides.
Thank you, Carol. We had a raised hand from Maria Morales. Maria, would you like to ask your question?
Thank you, Dr. Fernandez. So I'm Maria. I'm with Project Dana, and I wanted to ask who are the other community partners, community-based organizations that are currently active in United Us here in Hawaii?
Yeah, we have actually I have a slide. I'll just read it off from the slide. We have
Yeah,
about
sorry, I missed
Oh, no,
the
that's okay.
earlier part of the presentation.
Yeah, I
Thank
can
you.
share. Is it okay if I share it real quick, the slides?
Yes, please. Please
Okay,
put
yeah.
your,
These
put your slide.
These are some of our partners. The slides. This is our Oahu partners. So you recognize a lot of them: Healthy Mothers, Healthy Babies, Our Kapuna, Hawaii Food Bank, the Food Basket, Salvation Army, U.S. Vets Waianae. So those we have about 200 plus partners and about 400 different programs under the partners as well. Council for Native Hawaiian Advancement. So this is many of our partners that have maybe one or multiple programs on our network. We let them decide how they want to come on. And then here's our neighbor island partners. You probably recognize a lot of FQHCs have joined. A lot of our Native Hawaiian health centers have joined as well. Hawaii Island Community Health Center, Big Island Substance Abuse Council, Waipaki Community School for Adults is a great partner. So we have multiple service types. So anybody can pretty much who's a direct service can find a place because we want to be able to provide a gamut of services, an array of services for.
Thank you, Carol. Carol, could you tell us the cost, like who could access the Unitas for free?
Yes, thank you. Great question. So our community-based organizations are FQHCs, and anyone providing nonprofit direct service can come on at no cost. So those are the people that are doing the work. They're serving in those rural communities. So we provide unlimited free licenses to them at no cost.
Thank you, Carol. And we have a question from Valerie Rose. Valerie says, we are struggling with data and showcasing community impact. Could you please touch on how Unitas has been able to show data and community impact?
Yes, that's a great question, Valerie. That's actually the why is we want to provide the data to everybody. So our healthcare plans have data into referrals, outcomes, demographics. They have full data. We have Tableau, which we call insights data. So they have lots and lots of data, health equity, lots of data. And then our community-based organizations, we give them access to Tableau, the community data, so they're able to access as well. So it's all through Tableau and lots of data for many different questions that you might have as far as community.
Thank you, Carol. And we have John who has put the evaluation link. This is to get CME credit. Please complete the evaluation. Other questions from our participants today? We have Maria has a question. Carol, are you the person of contact to learn more about participating with Unitas?
Yes, I am. I am your Hawaii contact. So I put my information in the chat, but I can put it in again if that's helpful, Maria.
Thank you. Thank you, Carol. Other questions from the group?
Just to confirm, you said any patients with Aloha Care have access?
Oh, yes. Currently, actually, our Aloha Care, we partner with Aloha Care. Kaiser Permanente is also a partner with us, a prosecutor's office in Kauai. So they're partners with us, our healthcare partners, and then we also have our community-based organization as partners as well. And they're the ones that get to join it, don't join at any cost, our FQHCs and our Native Hawaiian Health Centers.
All right, I would like to extend a big thank you to our participants for attending today's ECHO Geriatric Clinic. I would like to convey my deepest thanks to our presenters, Carol from Unitas and Valerie from Aloha Care for sharing how we can improve the social determinants of health in our Hawaii community. Thank you so much for doing thanks for Akapuna for helping us create a better community and live with Aloha. Thank you very much. Have a good day. Please come